Okay, so I would like to move a little bit backward from the skies of interventional endoscopy to everyday routine practice. I would like to show you what kind of tools we have to do the best for our patients for diagnosis and surveillance of patients with Barrett esophagus. As an introduction, so GI endoscopy and tissue acquisition are of course very fundamental for diagnosis and of course for next management of patients with Barrett esophagus. The proper collection of tissue is the first step, and this is the most important step. After then only we can have information from pathologists what kind of tissue is there intestinal metaplasia, what kind of dysplasia is there, or early carcinoma, etc. So this is the very important first step. And of course, as was mentioned, the communication between endoscopies at your facility with your pathologist is very important. Transoral endoscopy is still the gold standard diagnostic tool for diagnosis and surveillance of patients with Barrett esophagus. Unsedated transnasal endoscopy can be used. From studies we know there are comparable rates of non-dysplastic Barrett esophagus detection. Can be considered as an alternative technique for screening. But there is more problematic tissue sampling because working channel is not so large. That means large capacity biopsy forceps, as I will show you, they are better. So this technique, transnasal endoscopy, is not recommended in routine Barrett esophagus surveillance. So first steps is very important. So of course we have to look for columnar epithelium, and it should be clearly visible and should be more than 1 centimeter. As a first steps, it's important to assess the landmark. If there is hiatal hernia, what kind, where is the position in centimeters, etc. But the most important is to proper position to recognize gastroesophageal junction. From our knowledge, the proximal limit of the longitudinal gastric folds is important. Important also to have minimal air insufflation, and of course squamo-columnar junction, the recognition. This is important, also distinguished from irregular Z line. So these are the tongues of columnar line epithelium which are shorter than 1 centimeter. In this scenario, biopsies are generally not recommended, and be where you should report that they are biopsies from GI junction, not from Barrett esophagus. This is very important for patient and next management. So more than 1 centimeter. Most of us, we've been in Prague in 2006, the Prague famous CNM classification system for Barrett esophagus, they were presented. We know this is consensus driven, very explicit criteria. From studies we know they are validated and they were reproduced in the different populations. So they are recommended for everyday practice. So important is to record the length of circumferential and maximum extent of columnar line esophagus. All 3 landmarks should be reported, as I mentioned, plus any separate islands above it, they are also important to mention for next management. They are usually seen after ablation therapy. So minimum endoscopic data set, or what should we report in every practice, not just the Prague criteria, but also we have to look for any visible lesion. This is very important. We should report it, we should measure where is the position, and also, of course, we should use Paris classification. This is very important for next management, for next endoscopies and tertiary center, etc. So what we have now in terms of biopsy protocol, everybody knows the famous old Seattle biopsy protocol. We firstly started with targeted biopsies on any visible lesions, and after then recommended 4-quadrant random biopsies every 2 centimeter. In the case of dysplasia, every 1 centimeter. This approach is safe, we know from the studies, is recommended, but we know also it's very time consuming. And from studies we know there are only limited adherence to this protocol from 10 to 80%. Which this adherence is much poorer for longer segments, which is the problem, and in failure to adhere with this protocol, studies shows there is significantly lower rate of dysplasia detection. So of course the future randomized trials will compare cost effectiveness with another alternative techniques can be done maybe in the future, maybe targeted biopsies guided by advanced imaging technique. So what are detection essentials? What should we do? Now most of us, we have an approach to high definition endoscopes. We should see the subtle superficial abnormalities. Careful cleaning, of course, of the mucosal surface is important. We can use some mucolytics agents, our anti-foam agents to disperse excess mucus and bubbles. Very important is to repeat endoscopy if it is needed with sedation, usually. If previous endoscopy was not very well tolerated and full biopsy protocol was not done. Of course, in case of esophagitis, we should accelerate PPI therapy for 4 to 8 weeks, and after then we should repeat endoscopy. Another essentials are inspect carefully by varying insufflation and desufflation, we know it. Important is to use retroflex to inspect distal part of Barrett esophagus, see more, biopsy less. It's a very famous quotation. So targeted biopsy before random biopsies. Distal areas should be biopsied first to minimize obscured view from bleeding. And diagnostic endoscopic mucosal resection of suspected lesions, they are much better, I will show you later, than targeted biopsies for staging. By latest guidelines, American College of Gastroenterology, in suspected Barrett esophagus, at least 8 random biopsies should be performed to maximize the yield of intestinal metaplasia on histology. Of course, in short segments, at least 4 biopsies should be performed. Very important is time, because Dr. Gupta and co-workers showed us that more time you spend in the esophagus, there is much more chance that you will find patients with suspicion lesions and patients with high-grade dysplasia or early adenocarcinoma. So this is really important. So on more than 100 patients, they showed that there was direct correlation between the mean Barrett inspection time per centimeter. So this is really important. There is some, it's very similar to colonic withdrawal time and adenoma detection rate. Another tool, helpful tool, can be use of acetic acid chromoendoscopy. On left, you can see this is standard endoscopy without acetic acid. This is after acetic acid diluted, and you can see this aceto whitening and enhancement of the architecture of the colonic of Barrett esophagus. And this is really important, that part where there is dysplasia, this aceto whitening disappears much sooner than other areas. So this might be very helpful for a proper acquisition, for proper biopsy. But so far, no randomized trial demonstrate any benefit, clear benefit over standard white light endoscopy, but there are many positive observatory studies, so of course we need more data. And some latest meta-analysis was published this year, acetic acid chromoendoscopy for diagnosis of early neoplasia and specialized intestinal metaplasia. This meta-analysis showed us that there is an overall high diagnostic accuracy for detecting early neoplasia. You know, nice studies, sensitivity very high, the specificity, but for intestinal metaplasia there is high sensitivity but very low specificity. So of course we need histology confirmation. Another way of how to be better in everyday practice is to maybe use the turn and the suck biopsy technique. The technique was first introduced or published in 1991. So in this technique, we know that taking biopsy in esophagus is sometimes cumbersome, problematic. So with this technique, it might help you. You put biopsy forceps before, after then open the cups, pull back. After then, you have to put end of the endoscope against the wall, little suction, and after then close biopsy forceps and narrowing the endoscope and slowly pull back. This technique might be very helpful, and from the studies, in this study they show that allows better tissue sampling. The samples were about 50% larger, more adequate, with better orientation, so it might be also helpful. About biopsy forceps, of course, everybody knows the larger the better in specimen size, the quality or orientation. We can use standard capacity, large capacity, or even jumbo biopsy forceps. In original Seattle protocol, this protocol was based on the use of therapeutic endoscope together with jumbo forceps. Jumbo forceps, the studies showed us, were superior to standard or large capacity forceps, but of course there is problematic maneuverability and tissue sampling with therapeutic endoscope, and not everybody have access to therapeutic endoscope. So maybe the best approach, the best way is the middle way, so to use the standard endoscope with good maneuverability. The patient, this technique can be of course better tolerated to patient, and you should use large capacity forceps, and also ASG recommend to use the large capacity forceps. Another possibility, Christian L. with co-workers introduced the technique of spraying of diluted epinephrine before biopsy. They performed studies, randomized studies in two arms, 20 patients with just saline or diluted epinephrine, and they showed that this dried biopsy technique is safe and facilitates thorough performance of these systematic 4-quadrant biopsies. For histology, they had improvement visibility, and there was also reduced time of sampling. So maybe you can use diluted epinephrine before biopsy. There will be no such high bleeding. Endoscopic mucosal resection is very important for staging. Of course, the important is to firstly find some mucosal abnormalities, some nodules, and these nodules, of course, should be sampled separately before these random biopsies. But today, preferably with endoscopic mucosal resection. Of course, in case of inability, you can send the patient directly to tertiary care center. And there was also an important study on 75 patients with biopsy-proven high-grade dysplasia or early adenocarcinoma, and endoscopic mucosal resection after then altered the original grading or staging in about half of the patients. That was downgraded or upgraded, so this is really important. So what about newest advanced endoscopic imaging technique? Can be helpful with patients with Barrett esophagus? Can we replace random biopsy protocol? Can we decrease the number of biopsies? So this is all very important questions. So far, maybe the most studied part from this advanced endoscopic imaging technique, of course, was narrowband imaging. The Pratik Sharma with co-workers, they performed study and they were compare standard high-definition wide-light endoscopy with Seattle protocol to NBI targeted biopsies. It was on more than 120 patients in 3 tertiary referral international centers. With NBI technique, there were fewer biopsies were needed per patient. NBI detected more dysplasia, and normal NBI pattern was truly normal, but you know it was very high international centers. So generally from the studies we know there is only moderate inter-observer agreement for the interpretation, and we know that this technique requires high level endoscopic expertise now. So maybe in the future with better education, some studies which showed us it will be much better. Another technique is chromoendoscopy with methylene blue or indigo carmine, maybe on meta-analysis not better, in everyday use definitely. With virtual chromoendoscopy I showed you, and NBI yes, but in other techniques so far insufficient data. With autofluorescence imaging technique we know there is high sensitivity, but of course also high false positivity rate. And in other techniques, confocal laser endomicroscopy, spectroscopy, optical coherence tomography, molecular imaging, definitely further studies are needed, and these tools are not for everyday use definitely. So far, also by guidelines, these newest and advanced endoscopic imaging techniques are not superior to standard white light endoscopy in Barrett's esophagus surveillance. So, ladies and gentlemen, let me conclude. Tissue sampling is the cornerstone for diagnosis and management of patients with Barrett esophagus. Essentials for appropriate, let's say, everyday routine clinical practice is to use standard endoscope, high definition if it's possible, with large capacity forceps. Now the best way is to good adherence to Seattle protocol, see more, biopsy less, do it slowly, do it right. Helpful additions may be to use acetic acid chromoendoscopy or diluted adrenaline. I showed you maybe you can use the turn and the sack technique. Diagnostic endoscopic mucosal resection of suspected lesions are better than targeted biopsies for staging. And in everyday practice, definitely we should learn to use virtual chromoendoscopy, at least NBI or what you have at your facilities. So far, advanced endoscopic imaging techniques, we need more data. We need reproduction and validation of these techniques, of these findings. Thank you very much for your attention.